Hello, I'm Dustin Thomas. I'm a cardiologist and the current chair of the SCCT Advocacy Committee. And in combination with the Education Committee, the Advocacy Committee would like to bring you this educational offering to help educate the cardiac imagers in the community and what we can do to help right-size coverage and reimbursement for CCTA. I have no pertinent disclosures. So we're going to talk a little bit about the differences between coverage and reimbursement and define those terms. We'll talk about some of the differences in the structures between private payers and Medicare. We'll talk about the codes, the Category 1 codes that cover CCTA currently. We'll go into a little bit more detail about some of the more recent trends with CMS with regards to reimbursement for cardiac CT and its various codes, as well as compare it to some other similar higher volume modalities such as SPECT. We'll go into a little bit more detail about how these evaluations for these codes are arrived at by CMS and give some tips about some ways that we as imagers can help to improve the reimbursement and right-size that reimbursement rate for us moving forward in our practices. And then we'll talk a little bit about some of the RUC surveys and things like that, and then we'll go into some detail about advocating with private payers. So starting with coverage. So coverage is essentially the list of benefits within a specified region or under a specific plan that people that are under that plan are eligible to receive. CMS uses LCDs and NCDs, which is local coverage determinations, LCDs, or national coverage determinations, NCDs, to govern these policy languages. Currently for CT, we have no national coverage determinations, which is important because a national coverage determination must be covered by all Medicare administrative contractors across the country. LCDs are local to specific Medicare administrative contractors and can vary between regions, although recent changes to statutory policy may bring more of those LCDs into alignment. Private payers, on the other hand, typically have proprietary, sometimes more difficult to review policies that are specific to each coverage provider nationally. However, there's significant local variability even within a national provider, and there's a lot of latitude granted to these local and state entities that fall under these large national providers such as United and Aetna and Anthem to draft local policy, and this is the perfect venue for which all of the members can engage with their local payers to improve coverage for all. Reimbursement is the actual payment given to the physician or hospital system for services rendered to a beneficiary. Despite the fact that something may be covered does not necessarily mean that it will be fully reimbursed, certainly at the price that, with which you bill it. And there's significant variability between payers, both nationally and locally, as far as how they pay for and cover these tests. Medicare, on the other hand, specific in comparison to private payers, pays based on a rulemaking process that takes 2 years. So data from 2017 will inform 2019 reimbursement rates for Medicare. And so that's why some of the things we'll talk about here later in this session will highlight the vital importance of us capturing good data to improve this. Some of the key things that you can, interventions that you can do as an imager to maximize your reimbursement and payment is to ensure standardization of your protocols, to ensure standardization of your reporting templates that are in line with published guidelines and meet all the specific metrics required by Medicare and private payers for billing, which includes having an indication for the test and a final diagnosis. And then to ensure that these patients are appropriately dispositioned and that the services are rendered in the appropriate setting. So looking at how these two payer systems are broken down, private payers typically have a medical director, typically a physician. Doesn't necessarily have to be a cardiologist or a radiologist or someone with imaging training, so sometimes this is an appropriate avenue for education on the local level. Many private payers delegate review and prior authorization duties for advanced cardiac imaging to include cardiac CT to specialty benefits managers, which have their own medical directors and usually have their own separate coverage policies with which the private payers can choose to adopt or not. In general, engaging with both is typically required when looking to change coverage. CMS, on the other hand, like we talked about, is the care is actually administered and covered and paid for through Medicare administrative contractors, which are regional companies that cover large swaths of the U.S. Currently, as we talked about, there's no formal NCD for cardiac CT, And so we're relying upon LCDs to garner coverage and reimbursement for cardiac CT services. These LCD and NCD processes are formal, they're public, they're transparent processes in which these coverage policies are made, in comparison to private payers where coverage policies are made internally and may not be as open and transparent and readily available to the public. So here are the 4 Category 1 CPT codes for cardiac CT currently. 75571 covers non-enhanced cardiac CT for calcium scoring, and then the remaining codes cover cardiac CT angiography for structure, congenital, and for coronary artery assessment respectively. These codes were granted in 2010. So we'll go into a little bit about some of the reimbursement trends for CMS over the last 3 years. So if we look at the professional component for the 4 Category 1 codes for cardiac CT, you can see relative stability in the physician component reimbursement for this test over the last 3 years. Likewise, with respect to the technical fee through the OPS rates for cardiac CT codes, you can again see relative stability. But to me, this is the most telling slide. So if you compare reimbursement for cardiac CT for the professional component between CT and SPECT, what you can see is that cardiac CT is relatively well compensated with respect to the functional SPECT testing for the evaluation of coronary disease. But with respect to the technical fee, which is granted to the hospital system or practice, there is a wild discrepancy between reimbursement rates, with SPECT being reimbursed at roughly 6 times the rate of CT for that purpose. To me, this is one of the single biggest drivers for why CT, despite data showing benefit and good patient outcomes, has not had widely uptake and adoption across the country at an appropriate rate. So let's talk a little bit in more detail about how CMS arrives at these technical component establishments. So the first thing that they take into account is cost, and this cost number comes from each one of your hospital systems. So the hospital files a cost report with CMS annually. It breaks down the operational cost on a departmental basis. Since procedures like cardiac CT are not a discrete entity that hospital systems purchase on a regular basis, it sometimes becomes difficult for them to accurately and quickly capture all the cost involved with performance of that exam. And so it's reliant upon us as the experts in the field and in our departments to advocate with administration to ensure that the cost for CT is well captured. Because CT is typically such a low volume test in many hospital systems, it's likely that your hospital is associating the cost with cardiac CT in a similar fashion to CT angiography of a single organ system, and we'll see what that's left us with here in a few slides. This is by all means not an all-inclusive list, but this is just some of the things that go into performing a cardiac CT scan that need to be taken into account. The staffing, the time for prep and recovery for nursing staff, for technologists, all the various durable goods that are used in preparation for this, as well as some of the medical supplies that are used as well. So how does CMS then take these cost reports that they receive and get to an estimated payment and cost? And so this brings into the discussion the thing called a charge master, which is essentially a list of hospital-specific charges for any given procedure. So it's a list of CPT codes with charge rates next to it. And in combination with this charge master, CMS then applies a cost-to-charge ratio, which takes into account the billing code with which is used, the department and setting with which it's used, and these cost reports, and it arrives at an estimated cost. And these estimated costs are then used to determine a geometric mean. And this geometric mean reimbursement rate is then used by them to place CTs and CPT codes into APC bins, or ambulatory payment bins, where they're lumped by similar procedure and similar cost. And so what that's left us with is, as you can see here on the far left, the APC code 5571 is where all the 3 of the cardiac CT angiography codes exist. And as you can see, the mean APC mean geometric mean cost for these runs to around $227, of which 75574 reimburses it slightly higher than that. As you can see, all other single organs. If you had to ask me what are some of the major factors that are affecting CT reimbursement through CMS right now, this is what I would say. So as we just talked about, the APC allocation, likely due to underreporting of cost, has really hurt reimbursement. Additionally, inappropriately low charges on CT charge masters across the country. If you look at the CMS data, raw data that they use to establish rate setting, what you'll see is that there are centers across the country that charge as little as $1 for calcium scoring and as little as $28 for coronary CT angiography. It's charges like that that are obviously not consistent with the actual cost of the test and drive the rates for reimbursement down significantly to inappropriately low rates where it becomes difficult financially to maintain CT coverage. Additionally, in 2014, CMS established CT and MRI cost centers to better track utilization of these resources, and as a result, the CT and all the CT examinations were pulled out of the diagnostic radiology cost centers and placed into their own cost centers, which resulted in a nearly threefold reduction in the CCR, which is the fraction with which the charge master number is multiplied by to arrive at the geometric mean cost. And so if centers have not appropriately adjusted for this reduction in CCR, then that is yet another example of how reimbursement is being driven down by poor reporting of charges and cost and billing practices. And if you think about how CT is a fairly low volume test across the country, if you have centers that are relatively higher in volume with problematic billing practices that don't accurately reflect the resources and time and effort required to do this important test, then you can see how there would be a significant impact in the rates nationally. Shifting gears a little bit away from technical fees and technical component of payment through CMS to the professional fees for cardiac CT, the RUC process and the RUC survey are the most important drivers of this. So this is a confidential process by which the committee, the RUC committee, establishes how much physician time, mental effort, and risk is associated with a new or revised CPT code. This RUC process is a committee that falls underneath the American Medical Association, and this committee then makes recommendations to CMS regarding the amount of time and effort and the estimated evaluation that comes along with a particular code. Medical societies are responsible for surveying utilization members as part of defending valuation assessments by the RUC, and these surveys are very important. So if you receive a survey from the RUC, from the AMA RUC committee, it's very important that you take the time to thoroughly evaluate your practice, your workflows, and to fill these out in a thoughtful and thorough and complete and accurate way so that you can be accurately represented when it comes time to paying you for your services. SCCT is actively pursuing AMA House of Delegation status, which requires a sufficient percentage of SCCT members to be AMA members, and this House of Delegation status would allow us to defend valuations and code settings for cardiac CT specific codes in the future with CPT and RUC process. So let's shift gears completely and talk a little bit about engaging with private payers. There is no magic bullet when it comes to engaging with the private payers, but I think this list that we'll go through here is a nice starting point if you're just getting started in practice and want to know how to do this successfully. So the first thing is to prepare yourself for success and be prepared. And the easiest way to do that is to know your audience. For those of you that are early in career and just starting in private practice or in academic medicine, one of the easiest ways to know your audience is to approach your coders and your billers and ask them who the biggest payers are in your local area. Many times they'll already have the name and contact information of some of the medical directors for these payers, and I would recommend you to search these payers, look up and see if they have their coverage policies listed online, and review those coverage policies for any issues that you might perceive with your practice. I would recommend looking up the medical directors personally. A lot of times these people are published or are academically involved and have put data out there that might help give you an idea of their thought processes when it comes to establishing coverage policy and language. Start with an email. Introduce yourself. I think it's very important for you to address this as a relationship building operation. So I would start with an email, talk about your background, talk about what's important to you, and keep in mind that the vast majority of payers have mission statements that reflect keeping the patient and their outcomes at the center of their coverage and their care. And so it's important for you to advocate on behalf of that and try to align yourself with their vision as much as possible, which will likely result in better coverage and reimbursement moving forward. While email as an initial starting point is a good place, I would strive for either telephone or in-person follow-up as a way to continue to build that relationship. And there are some resources through the society that we'll go over here in the next couple slides that are there to help you do this. If you go to the SCCT.org website, what you'll find is there's an advocacy tab that has a number of resources that are at your disposal as a member to use as you start engaging payers on this behalf. So the first thing is the interactive payer map. This is a map where if you click on your state, it's listed by payer as far as the various coverage policy language that pertains to the 4 cardiac CT codes. And so this is a good starting point when you're looking to assess what's covered and what the coverage language looks like in your local area. This is updated about every 6 months and is new to our website. It's always better to have strength in numbers. Ultimately, you may be successful as a single practitioner approaching a payer and garnering favorable coverage language. However, payers are inherently trained through experience to be skeptical of increased utilizations of newer technologies. They think that it automatically results in layered testing and increased cost, and so it's important to, if possible, to build a coalition of your local members, your local colleagues, your contemporaries in the area as much as possible to approach them with a uniform, united voice, because this will likely carry more weight with the payers as they would feel like they have more buy-in from all providers within the local community, not just one. But with more people and a bigger coalition comes the risk of getting off message. So be sure that the group that approaches the payer is clear about what the ask is and try as best you can to stay on message with that. Hone what it is you're asking for. Particularly if there's a focused coverage challenge, focus on just that challenge. Be specific. If coverage policy for cardiac CT, which is a very broad category that covers valvular heart disease and structural heart disease and pre-procedural planning and cardiac CT for the evaluation of coronary disease, it's probably too broad to ask for better coverage of cardiac CT as a whole. I would recommend a more focused approach, such as I'm seeking cardiac CT coverage as a first-line test for stable chest pain in patients that do not have established coronary artery disease. That's a very narrow indication and is one that encompasses a lot of the patient volume that we see in our practices. And if that is the ask that you're going to your payer with, the SCCT website has a tool to help you do this. So this is an executive summary that was written and vetted through some of the experts in the field that have written a lot of the science that we enjoy today. And this is downloadable in PDF format and can be used as a very short, concise review to give to payers that they can read and review. And it comes with a link at the end of that document to all the references that were used in the writing of this document. And so that is references that can be then given to payers if they ask. If in fact what you need is a complete overhaul and there is no local policy, or the policy is significantly dated and does not reflect the most recent data, well then the SCCT has a resource for you there as well. There is a model LCD complete with coverage policy language for almost every indication of cardiac CT that has again been written and vetted by the experts in the field, and is it there for your disposal and use either in its entirety or piecemeal if needed, and for download on the website there for our members. Moving on to some other important steps, keep the focus on the patient. Remember who ultimately stands to gain from better coverage for this important technology. With data showing improved outcomes and improved use of preventative medications and patient satisfaction and cost benefits, this better coverage ultimately results in better care for our patients. And so it's important to remember that these payers and medical directors continue to be clinicians as well. They have patient experiences just as we do, and a lot of times clinical vignettes that are patient-specific showing benefits and outcomes can carry the day and can highlight ways in which improved coverage and loosening of prior authorization challenges can actually significantly improve the care of their beneficiaries. Be a good listener. Ultimately, we don't have a good sense and good visibility of a lot of the challenges that the payers are faced with. We see very sterilized data that is performed in a highly controlled fashion, and a lot of times that data does not reflect real-world practice, and so payers are much more savvy with what claims data looks like, which can be good, bad, or otherwise, and so it's important to listen to them about their reservations so that you can focus your the data gathering that you do in follow-up to try to appease their concerns moving forward. Volunteer to be transparent. Ultimately, your data, your real-world data, is almost as compelling, if not more compelling, to the payers than some of these randomized controlled trials. If you can demonstrate appropriate use without layered testing when not needed, and cost savings and patient outcomes with what you're doing locally with your utilization of cardiac CT, the payers will find this compelling. Many times the payers have the ability to track you internally through their processes, but I would encourage you, if you have the capability and the infrastructure to do so, to track it internally as well so that you can provide that to them on a periodic basis even without them having to pull it. And if you're able to demonstrate good test stewardships, there are a lot of clinicians across the country that have had success with significant loosening of prior authorization requirements with that kind of data volunteering. Because keep in mind that prior authorization is expensive for everybody. It's expensive for clinicians and their practices to have the infrastructure, administrative infrastructure to work through these prior authorizations, and it's expensive for the payers to have it as well, and that the vast majority of tests are ultimately approved. And then follow up. I mean, ultimately, it's like these are simple things, but ultimately, if you say you're going to deliver them data, you say you're going to get back with them and re-engage with them, do so in short and medium ranges. A lot of it depends on your ask, but ultimately the goal is to have regularly scheduled engagements with your medical directors. The turnover within the medical director and payer community is pretty low. So ultimately, if you intend to stay in a specific region for a long period of time, these relationships that you build earlier in your career with these payers can last decades and ultimately result in a long-term relationship that is based on mutual trust and ultimately improved patient outcomes and care. So in summary, when it comes to working with the private payers, all politics is local. That's not my phrase, that's an old phrase, but it's very true when it comes to working with private payers. And making that an investment in knowing your payers, knowing what motivates them, and knowing and demonstrating being a good steward of multimodality imaging and CT can pay dividends for the rest of your career. Be prepared when you go to engage them. Go in with a specific ask, build a coalition if possible, focus on one coverage challenge at a time when it's appropriate, and then obviously take advantage of all resources that the SCCT has brought to bear to help you to do this. Ultimately, be a good listener and keep the patient at the center of the discussion at all times. And transparency can significantly move the needle in removing barriers to prior authorization. With respect to CMS, reimbursement rates for this upcoming 2019 year will be based on 2017 data. So keep in mind there's always going to be a 2-year lag in reimbursement rates being changed based on current data. Currently, reimbursement for the professional component of cardiac CT is relatively high, particularly when you compare it to other modalities such as SPECT, but the technical reimbursement through OPS has lagged significantly behind SPECT for many years and is likely what is stunting the growth of CT across the country. The things that the imaging community can do to improve this long term is, from a technical component perspective, is to engage your local administrators. Take a look at the charge master. See what your hospital administration is charging for cardiac CT. Try to educate them on how important a test this can be for their patient population, their beneficiaries, and how they can improve outcomes and ultimately be a cost saver if done appropriately and billed appropriately. Make sure they're appropriately capturing cost locally. Sit with the radiology department or the cardiology department, whoever owns the scanner, and ensure that they're reporting accurately the total cost of performing that test at your site and reporting that to Medicare appropriately. And then when it comes to professional fee reimbursement or work RVUs, just ensure that when RUC surveys come out from the AMA that you don't blow those off. Those are important surveys, and that's ultimately how the amount of time that we need to read these tests thoroughly and accurately in the vein of good patient-centered care is very important in how they evaluate how much we get reimbursed for that. And if you're not already an AMA member and you are an SCCT member, consider looking into AMA membership in support of our efforts to represent you at the RUC and CPT moving forward. And with that, I'll close, and I appreciate your time and attention.